Hi, this is Dr. Syed Ahmed. Today we are going to talk about osteomyelitis. Uh, Osteomyelitis can occur with hematogenous spread or contiguous spread from skin and soft tissue infections. In children, hematogenous spread usually leads to osteomyelitis of the end of long bones, while in adults, it's usually the vertebrae. Hematogenous spread is usually caused by a single organism, while skin and soft tissue infection leading to contiguous osteomyelitis is usually polymicrobial, as in diabetic patients. Osteomyelitis is infection of the bone and is usually starts in the intramedullary region, and the pus then travels to the cortical bone and finally reaches the periosteum. It causes necrosis of the bone, and surgical debridement is sometimes necessary. Acute osteomyelitis is usually caused by Staphylococcus aureus, but in contiguous other organisms such as Staphylococcus epidermidis, streptococci, gram-negative organisms, and anaerobes may be involved, especially in diabetic patients. The diagnosis of osteomyelitis can be done clinically by probing the wound, and if the probe test is positive, it's highly likely that patient does have involvement of the bone and osteomyelitis. Second modality that's used commonly, other than the clinical diagnosis, is MRI. MRI is highly sensitive and specific, and it may also locate any abscess or fluid collection in cases of contiguous osteomyelitis. Other than MRI, CT scan can be done, especially in patients who have metals, and MRI is contraindicated. Three-phase bone scan also has high sensitivity, but is not very specific because it may pick up inflammation due to arthritis, degenerative changes, and inflammation. Bone biopsy is the gold standard, and surgical consult can be obtained for the bone biopsy, and interventional radiologist can also perform this procedure. Bone biopsy is gold standard because it provides not only the histopathologic diagnosis, but we can also obtain bone cultures and find out the causative organism for targeted therapy. The treatment of osteomyelitis is usually 6 weeks of intravenous therapy. Some cases may need 8 weeks of therapy, such as vertebral osteomyelitis. If there is deeper infection and CNS involvement is present with vertebral osteomyelitis, such as epidural abscess or spinal abscess, then 8 to 12 weeks of antibiotic therapy is required. Empiric therapy should be with vancomycin, as well as a gram-negative coverage with cefepime or zosyn. Vancomycin covers MRSA as well, and we can always de-escalate antibiotics once the culture results are obtained. In patients who are allergic to vancomycin or who have chronic renal insufficiency, daptomycin is an alternative choice. But with daptomycin, you have to monitor the CPK level because it can cause rhabdomyolysis, especially in patients who are taking statin therapy. Other than daptomycin, other anti-MRSA medications used for osteomyelitis include ceftaroline and linezolid. Linezolid is a bacteriostatic agent and is not the drug of choice because linezolid has toxicity such as neurotoxicity and can cause thrombocytopenia and serotonergic syndrome. Therefore, it's not used commonly for osteomyelitis. Newer agents which have longer half-life, such as dalbavancin, have shown efficacy in treatment of acute osteomyelitis. Dalbavancin is used as single dose injection, 1500 milligrams IV, which lasts for 2 weeks, and then repeat injection. Sometimes 1000 milligram initial injection and 500 milligrams additional dose after a week is utilized, and then the sequence is repeated again for 6 weeks. Other newer agents with longer half-life are oritavancin, which has a half-life of 10 days, and telavancin is used once daily regimen. Other blood tests that can be used to monitor the efficacy of the antibiotics are ESR and CRP. We can obtain the baseline level of ESR and CRP, and we can repeat it weekly to monitor the therapy. Bone biopsy is gold standard. As we discussed before, that it not only provides the histologic diagnosis, but also we can tailor therapy according to the culture results. The duration of osteomyelitis therapy is 6 weeks, and intravenous antibiotics are recommended. Oral antibiotics are not recommended unless in exclusive circumstances, except for in exclusive circumstances. Usually therapy is given for 6 weeks, except for vertebral osteomyelitis, where 8 weeks of therapy is given, and if there is CNS involvement, then sometimes the therapy is extended for 12 weeks. In patients who have osteomyelitis and retained hardware in bone, there is a high risk of staph aureus forming the biofilm, and rifampin is very effective in penetrating the biofilm, and it helps vancomycin or daptomycin to reach its target. Rifampin dose is 600 milligrams once daily, and it can also be used 300 milligrams BID. LFTs should be monitored while the patients are on rifampin therapy. That's all about overview of osteomyelitis, and we'll come back with more lectures on other infections. Thank you.